For arthroscopy, we use a 30-degree endoscope, meaning that the direction of view is 30 degrees in relation to the endoscope shaft. The total field of view is more than 90 degrees, thus our sight line includes the axis of the endoscope shaft. The light cable is connected to the endoscope to illuminate the intra-articular space. The light cable is virtually always positioned opposite to the endoscope's angle of view. The position of the light cable is indicated with clock positions. For example, positioning the light cable at 12 o'clock delivers a view at 6 o'clock. A 9 o'clock position of the light cable delivers a view at 3 o'clock. For each arthroscopy, the video camera is connected to the endoscope to transfer the intra-articular images to the monitor. There are three basic movements that control the endoscope: advancing and retracting, turning upward, downward, and medially and laterally, respectively, and rotation. Initially, these basic movements are exercised at the arthroscopic tower. If the light cable position is changed from 12 o'clock to 9 o'clock, we look in a 3 o'clock direction. If we position the light cable at 3 o'clock, we look in the direction of 9 o'clock. The position of the camera stays constant and is not turned in relation to the endoscope. By advancing the endoscope, we can clearly identify the structure. Retracting the endoscope gives us a better field of view, which is essential for orientation. In the course of moving the endoscope up and down, the entire arthroscopic tower can be observed. By rotating the camera, the picture on the monitor can be turned, while the endoscope remains in a constant position. In this case, if we have a sufficient field of view, orientation through scripture on the arthroscopic tower is still possible. Camera rotation within a confined space is now shown. Turning the camera, orientation is totally lost. We do not know where we are. Retracting the endoscope does not provide any additional information, and only the correct camera alignment is helpful. During light cable rotation, the camera stays in a constant position. Within a confined space, the light cable must be parallel to the space. Positioning the light cable at 3 o'clock, we look directly toward 9 o'clock. In this case, the tip of the endoscope lies very close to the left margin, which does not give an adequate view. The same occurs if the light cable is in a 9 o'clock position. During arthroscopy, the endoscope is inserted into a sheath and coupled to it by pressing until a click is heard. An irrigation and suction tube is connected to the rotatable stopcock. The whole system can be held by the camera, resulting in an extremely long lever that makes movements less controllable. But if we grasp the system with 2 fingers placed on the stopcock valve and the thumb on the light cable, we achieve better guidance. In addition, we are able to control suction with the index finger if needed. Positioned in an artificial knee, camera rotation can be controlled using the monitor image. If the tip of the endoscope lies very close to the anterior cruciate ligament, ACL, we don't have a sufficient field of view. Turning the camera leads to a complete loss of orientation. In such a situation, we retract the endoscope and turn the camera until the view of the ACL is correct on the monitor. The light cable is not moved. We are now turning the endoscope toward the lateral joint compartment and are visualizing the lateral meniscus. The light cable is in a 3 o'clock position. By positioning the light cable at 6 o'clock, we have a direct view of the cartilage of the lateral femoral condyle, but have no field of view of the lateral meniscus. If we position the light cable at 12 o'clock, we look directly at the posterior horn of the lateral meniscus. Here the field of view is also limited. The major part of the lateral meniscus is not identifiable. Only when the light cable is moved to the 3 o'clock position is a good field of view over the whole lateral meniscus and lateral compartment possible. We again show the basic movements. By turning the endoscope tip downward, the origin of the ACL is visible. Turning the endoscope tip upward shows the proximal cruciate ligament part. The origin of the ACL is even more visible if the light cable is rotated in the 1 o'clock position. The origin of the femoral cruciate ligament can be visualized optimally if the endoscope is advanced into the fossa and the light cable is simultaneously positioned at 5 o'clock.